plastic surgeons have traditionally shied away from doing hair transplants because it's like not real surgery. And historically, so this is, I have a personal interest in hair transplants because when I was young, my father was bald, and I could see that I was going bald at a pretty fast rate. So this is, I have personal experience of hair transplantation. So this is what the state of the art goes back to 1952, when the first surgery for male pattern baldness was performed, and a dermatologist, Norman Orentreich, in New York. And people complain about the difficulty of getting published. It took him 7 years to get his first paper on hair transplant published, because actually all the reviewers didn't believe it could be done. So this was his first paper, Autografts in Alopecias and Other Selected Dermatological Conditions. Now, this paper was seminal to hair transplant because it actually demonstrated that hair could be taken from the back of the head, moved to the front, and it would grow successfully. So what he demonstrated was that in male pattern baldness, the problem was not was the seed and not the soil, as he would put it. So, and the hair that was moved would actually grow in the recipient site exactly as it would have grown in the donor area. So from the 1960s through the early 80s, Orentreich's procedure was used, and what he utilized was a standard handheld dermatologic punch, because that was the only thing that was available at that time. It was the same punch that dermatologists would use to take biopsies of skin cancers, and those were typically 4 to 5 millimeter punches, because you wanted to send a decent size sample to the pathologist. And it was done manually. You took it and you just screwed down on this, and you got a fairly large graft. So this is what the state of the art was in the 70s. And yes, you could move hair. Yes, the hair would live, but it wasn't terribly aesthetic. It was a very doll's look, a very pluggy look. But again, this was the only thing that was available at that time because of the instrumentation that was available at that time. But believe it or not, a lot of people were doing this. And now when you look at it, you can see that the pluggy look is because the hair are all concentrated in one area, and then there's an expanse of bare skin, and then the next plug. So this was the common term, the plugs. Now, with refinement in instrumentation, manufacturers started making 2 and 2.5 millimeter punches, but the results were still pretty pluggy. So still the same problem, and you can see that this is not acceptable by today's standards, obviously, but people were having it done. Now, even when you took the grafts that you harvested manually and then dissected them out into smaller pieces, they were still pretty pluggy. So in 1984, it was first proposed to use smaller grafts cut from a strip of tissue taken from the donor area. And this was the birth of the strip procedure, which is still used in 90% of clinics in the United States today. And this is the traditional strip method harvest process. Now, sometimes it's now referred to as follicular unit transfer. Don't be fooled, it's still strip. Okay, so you take the strip. The biggest disadvantage of the strip, of course, is the donor site. There are other disadvantages I'll get to, but this is the one that patients first think of as the disadvantage of the donor, of the strip method. And but it's a very efficient procedure. You can take a strip in 15 minutes. You can hand it off to the technicians. And this was the other improvement with microdissection. So the technicians can then dissect out the follicular units that you see down here. The surgeon closes the donor site, another 25 minutes is gone. And by then the patient can be sat up, the recipient sites can be made, and the technicians are handing back the grafts. And so in about 4 hours, you can actually complete a strip procedure. And the results are actually pretty good. And I'll show you some results, but this is much better because you can soften the hairline. The hair is not so pluggy, and this is one of Dr. Bauman's patients from Florida. And you can see what happens. Pre-op, this is what the patient looks like. 3 days post-op. What has been implanted is the follicle with a little stub of hair, and this is basically a micro skin graft. Because you've gone down 3 millimeters, you've taken the epithelium, the dermis, and a little bit of subcutaneous tissue, and the graft is 1 to 2 millimeters. So what happens is the hair sheds, so at 3 months it looks like nothing was done. You just have the follicle implanted subcutaneously, and somewhere between 3 and 6 months the follicle has generated enough hair so that it emerges from the skin, and then it will just grow naturally. And this is actually a very nice result from a strip procedure. And this is a good surgeon who knows what he's doing. He hasn't filled in any of the temporal area. He hasn't wasted any of the skin, the grafts on the temporal area. He's concentrated on increasing the density in the central forelock area, which is basically the money shot where people see you from front. So this was the standard of care, pretty acceptable results. There were some problems with surgeons who didn't quite know what they were doing, because in an attempt to get more grafts, they would take a larger strip and have difficulty closing it, so they'd close it under tension, they'd get white scars, et cetera. But this is the typical strip harvest donor site. So this is the main disadvantage, but there's other disadvantages that we're going to come to. So the next major step was in 1995 when Robert Bernstein published the idea of transplanting exclusively naturally occurring follicular units. What a naturally occurring follicular unit is that where the hair emerges from the skin, it emerges as 1, 2, or 3, and there's 1, 2, or 3, and occasionally 4 units. So this is a follicular unit. And his concept was, well, that's how it occurs naturally, that's what we should be doing. We should try and achieve what occurs in nature. And this was helped by microinstrumentation. Because by the 1990s, what was introduced was motorized punches. So this was going back to Orentreich's procedure using punches, but now we had mini micro-motorized punches. And these are essentially dental hand drills with a punch at the end. I don't know why it took people so long to figure it out, but this is what this is. This is a dental hand drill. You can power it either electrically or with the air. And basically, you go in and you extract the follicle. So this is referred to as follicular unit extraction. You're extracting one follicular unit at a time. And you can see, to be able to do this, you have to shave the patient down. So there's about 1.5 to 2 millimeters of hair. You feed this through the punch, you push the punch down, and you move the punch out. And you can see here on the left-hand side, you can see these are the grafts. Now, because they are still tethered into the subcutaneous tissue. So you now have 2 options. You can take a microforceps and pull them out because they're just loosely tethered in the fat and the subcutaneous tissue. There have been some recent advances where you can put a suction on the end of the punch and try and suck the graft out. And that does work to some extent, but there's two disadvantages to that. One is the pressure injury to the graft by sucking it out into a bottle, and two, actually getting the graft, enough pressure to suck the graft out. So, the major advantage of follicular unit extraction, however, is the quality of the grafts. If you look at what the technicians can do by chopping a strip, the grafts look pretty rough. The grafts harvested by machine look much smoother, and even under higher magnification, just look much healthier. So that's the first significant advantage. Now, patients always think of the scar as being the major advantage. The fact that there is no scar, because basically you're using punches which are 0.9 to 1 millimeter, and it just heals fine, and so you have no scar. But actually, in my mind, the biggest advantage of FUE is the quality of the graft that you're harvesting. Better quality grafts give you better results. Now, the mathematics of hair transplantation actually give you another reason why follicular unit extraction is the way to go. If 1 square centimeter, on average, in the donor site has 100 hair. So if you take a strip 12 centimeters by 1 centimeter, and it's really pretty difficult to close more than a centimeter in the donor site. You get 12 centimeters square. The maximum yield you can get out of that strip is 1,200 hair. It's mathematically straightforward. The only thing is, no technician is good enough to get all 100% of the hairs. 80% is actually a pretty good harvest. So you're going to get about 960 hair out of the harvest. With follicular unit extraction, the donor site is the entire back of the scalp. So that's 30 centimeters all the way around, 7 centimeters high. You can't really go much more than 7 centimeters because you get into hair which the patient is destined to lose. You can't go much lower down, because then you get into the nape of the neck, and when you punch down, the fat just wiggles and it's very difficult to extract. So with the FUE, you have 210 centimeters square potential target area. If you take 8 hair from each square centimeter, the yield is 1,600 hair. If you get 12 hair from each square centimeter, the yield is 2,520 hair. Now, how many hair can be harvested is kind of difficult to predict, because it depends upon how deep the follicles are, how tightly bound they are to the subcutaneous tissue, and also if they're a straight shot or if the hair is a little bit kinky or curly. So when you talk to patients, you just have to tell them, we're going to do our very best, this is the range. And obviously patients who had prior strips who will come in, they've got less donor site and they also have scar. So this is the mathematics of hair transplantation. So this is an ideal patient who says, I don't care, doc, shave it all, get me as many grafts as you can. The reason he says that is because he's 22 years old, and if you look on the right-hand side, you can see he only has a few wisps of hair at the front and forelock area left. So he wants as many hair as possible. He's big, okay? Now the point is that grafts do not equal hair, because a lot of patients will call up and say, how much do you charge per graft? And you have to explain to them, actually, you don't want grafts, you want hair, right? And this is the maximum you can really harvest from a patient. It's actually only 1,064 grafts, but it's 2,626 follicles. And you actually count each of these. You divide your area into 1s, 2s, 3s, and 4s. Most of the grafts in most patients, at least 70% will be 2s, and at least 60% will be 2s and 3s. 4s are relatively rare. 1s can be quite common. So you've got 1,064 grafts, 2,626 follicles. So you're going to ask, in someone who's completely bald and just has a little hair around the side, how many hair do you actually need to get something that's cosmetically acceptable? And I'll answer that question later. But so this is the benefits of FUE versus strip. You have a strip, you have the follow-up visit for suture removal, you have long-lasting numbness in the scalp because you've cut all the nerves. There's a permanent visible scar, which is not so bad because if you wear your hair an inch or so longer, no one's really going to see the scar unless it's a very wide scar. The biggest disadvantage is it's difficult to reharvest if additional grafts are required. And since male pattern baldness is a progressive disease, all these patients will require additional harvesting. And then about 960 hair transferred on average. After FUE, it's actually difficult to get the patients back in the office. There's no follow-up visit for suture removal. They have short-lived numbness in the scalp from the multiple holes. There's no visible scar. The biggest advantage, easy to reharvest if additional grafts are required, and about 1,800 hair transferred on average. So, this is what 1,800 hair transfer looks like. This is a gentleman pre-op. This is at 6 months. Now, they've not all fully grown in. It really takes 12 to 14 months for every single follicle to go through its full cycle of growth. And so it will look more dense. So essentially, you shouldn't fill in till 12 to 14 months. So this is pre-op. This is immediately after transplantation of 1,800 grafts. So when I talk to patients, I don't talk about how many hair or grafts we're going to put in. I talk about how far back we can fill in, and usually in one session we can do 1/3 to 1/2. And as you can see in this patient, that's about how far we got. We got back to about half. The posterior half, the vertex, has not been grafted. So when he comes in for a second session, we'll fill in more at the front and we'll fill in at the back. You really don't need a lot of density in the back because that's not where people are looking at you. Most of your follicles should be transferred to the front. Because how many grafts you need is the wrong question, it's a question of how many hair you need. Since normal is about 100 hair, a cosmetically acceptable appearance can be achieved with 35 hair per centimeter square. So measure the area to be covered, multiply by 35, subtract the existing hair count in that area, and that's how many hair you need. However, since male pattern baldness is ongoing, always overcorrect. And always harvest as many hair as possible, given the donor site and the recipient site you have to work with, so then patients don't have to come back for 6 or 7 years. Patients all have their own ideas of what they want. Physicians are the worst patients to have because they think they know it all. So this guy's a physician. And this is about 1,200 hair that have been transferred. So this is before surgery, day of surgery, 6 days of surgery. And you're gonna ask me, why did we only transfer 1,200 hair? When you've got all this and you can get 2,500. The reason is because he's a physician and this is all he would allow us to shave. This is pre-op and you can see post-op. He said, I don't want you to shave there, I don't want you to shave there. Well, we don't have the maximum donor area. So he said, no, do what I say. Okay, that's what you want to do, that's what you want to do. Of course, 6 months later, he comes back and says, no, I was all wrong. You know, next time you shave completely, you know, do whatever you want. But we all have patients like this who think they know more than you do. One of the big disadvantages is the shaving. So, because patients don't want to go back to work, they don't want to take 10 days off work. So this is what I call the executive harvesting session. If you have your hair long, you can flip your hair up, you can shave that area, and you can go back to work once the hair is flipped down. So this is that's one way to get around that problem. But you really need to have quite long hair to be able to cover 2 inches. So your hair really needs to be at least 2 inches long so that you can cover that. And here's another patient, and we did basically a mini procedure. And every patient has their own requirements, like, I don't want the strip, I don't want to be shaved, I want to go back to work the next day, and what else do I want? And the answer is, well, you can't have all of that, okay?
They don't want to pay. They don't want to pay anything.
They don't want to pay anything either. So this is a mini harvest, but this actually worked for this guy because you only needed a very small number of hair, and you can see 4 days later the donor site is almost completely healed, and when he puts his hair down. So what did he actually need? This is about 250 grafts, and basically all he wanted was to get rid of the shine on the vertex. And with that you can cover that area. This guy had previous experience with FUE, and the important thing about FUE is it looks completely natural. You can go in there and it just looks completely natural because that's what the patient had. And that's the benefit of follicular unit extractions, because you're extracting exactly what nature put there, and you're transferring and putting in exactly what nature had. The problem with hair transplant as a specialty is you can't compare A and B, because looking at this guy on the left, you don't know what he would look like 6 months later. This result is actually much better than it looks, because he would probably have lost 6 months to a year later, he would have lost, because you're always shooting at a moving target. It looks good, but it's actually much better because this guy is probably on his way to completely losing all his hair. So this is part of the problem of doing hair transplants, that it is, patients are reluctant to accept the fact that, all the grafts you put in have a 95% survivability, but the patient comes back 2 years, 3 years later and says, I look exactly like I did before you operated on me. And you say, no, that's a great result, because what would you look like if you hadn't had the procedure? So the best patients to get are the ones who are completely bald, because they can see every graft that you put in. And the thing is that if you're completely bald, how many hair do you need? And the answer is approximately 8,000 hair. Yeah. So if you can put in approximately 2,000 hair per session, if a patient is completely bald, they're going to need 4 procedures. And a procedure with FUE takes twice as long as a procedure with FUT. Because with FUT, you can do an FUT procedure in 4 hours. With follicular unit extraction, the patient can't sit up until you've extracted all the follicles. The patient is lying face down while you're extracting one by one. Then you have to break for lunch because you're tired, and then after lunch, you can implant. So FUE takes much longer, and basically it's an all-day procedure, which is why most of the commercial clinics continue to use FUT or strip, because it's more profitable for them. So this is what 8,000 hair look like. So, that's the thing. The future directions, there's the potential for robotic extraction is there. There are some machines on the market. The best known one of those is the Artis machine. And it's available now. There's about 25 machines around the country have been installed. And there are a lot of disadvantages though. The equipment is expensive. It's $250,000. Yes. Wow. And then you need a dedicated operative area for this. You need specialty staff training, and then the company charges a per use fee. So it really can get to be very expensive. The other problem is that the target area that they can focus on is only 4 to 5 centimeters squared, so you're continuously repositioning the head. And the other disadvantage is, of course, graft insertion remains manual, so you still need a dedicated team of technicians to implant the grafts. Are there any advantages? Potentially. You take your 4 to 5 centimeter squared area, you can magnify it as much as you like. You can then try and harvest only 2 to 3 hair grafts, so you get more hair, so you don't get any 1 hair grafts ruled out. That's a potential advantage. It's been shown that they can, because basically what it is, you magnify the area, the head has a laser which points, and then the arm goes in, shoots. It still doesn't extract the graft. You still have to go in and manually extract the graft. It's only the punching that has been automated. Technicians are actually much faster at it. Because each hair is at a slightly different angle, you can move your hand much faster than the robot can move so there's really not that much advantage to date. Although, in terms of marketing, it's a huge advantage, right? You're going to have a robotic hair transplant. That's pretty much the end of the talk. So I'd be happy to answer any questions you have.
You got last time, so let's start in the back.
Dr. Schulman mentioned about the magic of what's in fat. And we've all seen the improvement in a radiated breast, what the fat transfer does, and into the face, how it often will improve the skin. Has anyone done fat grafting to the donor sites, to the scalp, to kind of counteract the atrophy that occurs in the aging scalp?
Not to my knowledge. Lots of stuff has been done. There's a lot of stuff in the literature about PRP injections to the scalp to grow hair, and I've tried that with very limited success. Basically, if the follicle is dead, no matter how many growth factors you put in it, the follicle is dead. You can't bring the follicle back to life. PRP, however, has one extremely useful role in hair transplant, which is that prior, when we took out the grafts, we would put them in iced saline to chill them. Now I put the grafts in PRP. The growth hormone, because basically this is just like any other skin graft. 5 to 7 days to revascularize it to become pink. In those 5 to 7 days, it has to be nourished. So if you can put the grafts in PRP, you get all these growth factors and nourishment, so it helps the growth. So there's papers showing that a graft in iced saline after 8 hours is essentially non-viable. So basically you have a window. Grafts in PRP are viable up to 4 days later. So there is, so if they're viable 4 days later, and you've utilized it while you were implanting, clearly you've given them a head start in their growth and becoming revascularized.
Staying with sort of ancillary procedures, what is your recommendation? Propecia, minoxidil, any?
None of them work.
Okay, and you don't, and basically it's hair transplant procedure and that's it. Give us your pre and post-operative care.
There's nothing special. This is basically as if you were doing a skin graft. You take a skin graft from the leg, you try to move it wherever you want. There's really nothing you can do to condition the skin where you're going to take the skin graft to make that skin take better and revascularize better. These are basically micro skin grafts.
And they're all done under local.
This is all. The beauty of this is all done under local anesthesia in your office. So that's the.
What is your local protocol? So how are you injecting them? How often are you re-injecting them? Are you using Marcaine?
Yes. So that's the key. You mix the lidocaine 1% with Marcaine 50-50. You add a little bicarbonate to make it less acidic. And you inject the local area. It'll last you 8 hours, and then after lunch you inject the recipient area. It's much like going to the dentist. I mean, it's really not, apart from the initial needle sticks, it's really not bothersome.
And is your recipient site an 11 blade?
It's actually much easier to use a 20 gauge needle. You actually just put the needle in and make a hole, because that's the size of the graft.
It was a PRP question.
Okay, great.
20 years ago, there was a Finnish company on the diode laser, but it became too tedious because people don't go back to that stupid head thing. What do you think the newer diodes they had, commercially around 372 diodes in the pack? What do you think that is?
Oh, for hair growth?
Can you repeat the question, please?
No, because the
Can't hear you.
diode
Can't hear
was,
you.
20 years ago, I was working with a Finnish company using a low light laser diode. And surprisingly enough, we had about 5 months study, but the men had to come in 3 times a week to use
Yeah.
the damn diode. And guys don't like to be in those big hats. And the improvements that made their commercial, I've never really
So-
been impressed with.
So the answer to the question is that the FDA has approved that for hair growth, just like the FDA approved minoxidil and propecia. But the answer to the question is, does it work? The answer is no. I bought one of those machines. I had a fair number of women who were interested, because females are, if you think men are bothered by hair loss, women go crazy. And they were willing to come in 3 times a week, sit under the light. 12 weeks later, no visible result, multiple patients. So basically, if you want to buy a diode laser, I have one. It has a doorstop, you know.
No, but the Allergan has done research with Lattice.
Uh-huh.
It's expensive, and they
Yes.
know how to produce it.
Mhm.
But people who are bald like a chrome dome will
Mhm.
get hair back. They've done small studies on that.
That may be the case.
That's for
That
sure
may be the
works.
case.
And there's a chemotherapy agent that on patients who are chrome dome bald
Mhm.
will, unfortunately, cause nothing sarcoma, or bring complete hair back. So there is work on it, just that I think this is the safest way to go.
Sticking with Lattice, have you done eyebrows, eyelids, have you done any other stuff?
I've done eyebrows. The problem with eyebrows is that what you're transplanting is not eyebrow hair. You're transplanting hair, and you have to warn the patients that you're going to trim your eyebrows every 2 days, otherwise it'll grow up. And if you warn them beforehand, then they're okay with it, it's okay, but if you don't warn them beforehand, they're going to be mad.
Hold on one second, go ahead.
I just want to address that question about the fat in the head, because while I've never done anything up here, one thing I have observed in some patients after BBLs is you do get significant hair growth on the butt. I've seen it. So I don't know whether something's stimulating, they have to start out with a little bit of fuzz, but it's something that I've observed a handful of times, and I don't know whether it's hormonal related to the surgery, because we all know hormone levels are all off the charts, or there's something real about the fat transfer, but there's, I don't know how you would really get into subcutaneous scalp well, but I've seen it on the butt.
Yes.
Any difference in your protocol?
No, it's pretty much the same, but it's easier with women. They have long hair. You can take a very large donor site, and they can go back the next day, and within 4 months, most of their hair will have grown back. They're a little bit leery when you first talk to them that you're going to shave this much, and then when you show them some pictures that no one's going to do this, and obviously it's much better than having a fixed or cut out their back.
And is there any role in men for scalp reductive procedures?
A lot of people have asked, the jury flaps and all these prior and the Frechette procedure for scalp reduction. This is actually what Donald Trump had 25, 30 years ago. So when his hair waves in that direction, it's because the jury flap is in that direction. So nowadays, I don't think any patient would subject themselves to a jury flap or a scalp reduction.
2 other questions. Any differences in ethnic diversity?
Yes. The best patients are the ones who have nice straight hair. African American hair is totally unsuitable for FUE because it's curly, and I don't know if I've got a slide here somewhere I can show you. Yeah, that's why, to answer your question. The shape of the hair is very different. The ideal patient is the one who has straight hair, you go straight down, you grab the follicle. If the hair is a little bit kinky, 90% of the time, if you angle it right, you'll still get the follicle. With African American hair, which is kinky and curly, you have no idea where the follicle is. So we have tried African American hair, totally unsuccessful. Total, the harvest was de minimis.
Are you doing a fair amount of Asians?
Yes, Asians are very interested in hair. It's in the culture that Asians are really, and you know, beauty is a cultural thing, obviously. In Asians, it's.
I for those who don't know, you're basically located in Englewood Cliffs, which is sort of a confluence of upper middle class Asians and African Americans. So you certainly have an experience with all of those. Alopecia areata.
The recipient site is scarred and really doesn't take grafts very well.
Any other questions?
Does hair color matter as far as your
No.
technique?
No.
It does matter as far as robotic technique, correct?
It matters in terms of visualization, but all you really need to visualize is that 1 or 2 millimeters that is left above the skin to point, so you can just color it and you can shoot in the hair. Of course, when it grows, it will be white hair that grows. It won't be.
I know all about
I
that.
know all about that. Because that's very interesting. The loss of color in hair. It's a very interesting subject, which is a topic of its own.
You mentioned initially that patients would call up asking for a price. How do you, you know, again, just being on the internet, you see lots of advertisements for, you know, $5 a graft or $2 a graft, or how does that work?
Okay, so this was Dr. Bosley's great innovation. You've probably seen Dr. Bosley's advertisements. You'll be pleased to know that Dr. Bosley actually had a terrific amount of training. He had 1 year postgraduate training. He was a general practitioner. Like most of the early practitioners in hair transplantation, they stumbled into this as a great way to make money, and most of them had very minimal training in not just surgery, in anything. I mean, they got their medical school, and as soon as they got a license, and they do this. Dr. Bosley's great thing was to be able to explain hair graft in what I call the Macy's model, which is buy one, get one free, you know? And it's very difficult to explain to patients because they've been inundated with this. And the other great thing about Bosley's model was he would have a central surgical site, he would have 6 or 7 peripheral offices. Patients would be marketed to, they would come into the offices, and they would be met by an image consultant, also known as a salesman. And the salesman would tell them, oh, we're going to give you 3,000 grafts, and it's only $5 a graft, so if you sign today, I can get you a deal for $4 a graft, and you know, so it was, they actually never met a doctor. The doctor only met the patient the morning of surgery, because the patients were then all funneled to the central surgical location.
Yeah.
Dr. Bosley sold his company to a Japanese conglomerate, and he got over $100 million for it.